Hello, and welcome to the Osteogenesis Imperfecta Foundation's monthly podcast. Each month, the OIF will be bringing you information about the diagnosis and treatment of osteogenesis imperfecta presented by an expert in the field of OI and rare bone disease. The podcasts are a part of the ongoing educational effort of the newly formed Brittle Bone Disorders Consortium, part of the National Institutes of Health's Rare Diseases Clinical Research Network. The professional education activities of the Brittle Bone Disorders Consortium are led by the OIF. Our podcast today will focus on multidisciplinary care in treating children with OI. We're very excited to have with us today Dr. Cathleen Raggio of Hospital for Special Surgery in New York. Dr. Raggio specializes in general pediatric orthopedics, scoliosis, and in treatment of osteogenesis imperfecta and skeletal dysplasia, and is the co-director of the Catherine O. and Alan C. Greenberg Center for Skeletal Dysplasias at Hospital for Special Surgery. Dr. Raggio is also on the OI Foundation's Medical Advisory Council and has spoken at a number of our meetings over the years. So, Dr. Raggio, welcome, and thank you so much for being with us today.
Thank you so much, Tracy. It's a real pleasure to be here. I love OI, as you know, and I think it's a very important topic that we can discuss.
Terrific. Great. Well, on our last podcast, we talked about genetics and the exciting research that continues to go on in this field. But once a person is diagnosed with OI and they begin their care, who gets involved with that care? And can you talk about developing that team of professionals that will care for, today we're talking about children with OI, and why that multidisciplinary care approach is so important?
Okay, so as we all know, once a child is diagnosed with OI, and that could be either at birth, it could in some of the more moderate forms of OI, or it could be later when they're age 3 or 4 in some of the milder forms of OI. So timing, I'm going to talk in some generalizations, I think, but the importance of a team. Why do you need a team if OI might just affect bones? Well, OI doesn't just affect bones. It affects heart, it affects lungs, and it's important to have a team in place of different professionals in different areas so that everyone's looking at the patient that has OI and giving their input, because you want, at the end, the goal is to have someone who has an excellent quality of life and is independent. And that's the goal of starting from beginning with a team and through your adulthood, keeping a team. And people always ask me, well, who should be on this team? And so I talk about the team, and then it's like playing football. At any given time, you might be running offense, you might be running defense, you might have the kicker on the field who's in charge. But you've got the team together, and as a captain of the team, I always say, I always ask the parents to really make sure that they're keeping everything in order. So just for team members, clearly you want the patient and you want the family on board. And for children, I always think, and for you pediatricians on the line, I always think it's the pediatrician who really has to be the team captain here to coordinate the care. What you're going to need is clearly an orthopedic surgeon who is willing or capable of caring for someone with osteogenesis imperfecta when they have their fractures. You're going to need your geneticist to help make the diagnosis, and you might need your geneticist and or an endocrinologist to be able to help administer the intravenous drugs that some of these children might need. On top of that, you're going to need a good physical therapist, and you're going to need someone who helps liaison with a school system, whether it's through the school system itself, where the patient has an IEP, or whether it's through a case manager if the patient's been in the hospital a lot for surgeries. But I think the beginning team should be the pediatrician, an orthopedic surgeon, genetics, endocrinology, a physical therapist, and the family on board. As a pediatrician also, you're going to want to have the child checked respiratory-wise, so you might want to have a pulmonary specialist and a cardiologist to check the heart. And again, as I said, who's going to be running the team at any given time is going to depend on the child's specific form of OI and what specific issues have come to the fore. So it is going to be a rotating basis of where the emphasis is on the team, but the whole team is always going to be working in the background, keeping the patient and keeping the child in the best shape they can be and giving their input.
Dr. Raggio, you mentioned giving different drugs, and that was the endocrinologist that you talked about. Can you talk a little bit more about that, what somebody could expect with the various types of OI?
Right. So once you are diagnosed with osteogenesis imperfecta, the patient will get their mutation, and they will be told they might have the milder form of OI, which we would call typically type 1. And generally those patients are not going to require any intervention with drug treatment. Drug treatment is generally used, and currently what we're using is bisphosphonates. And bisphosphonates are a class of drugs that work on slowing down the osteoclast, and they actually have the osteoclast die a little sooner. By that happening, the osteoblast, which is the builder of bone, gets more time to work to build bone. And so the way it works in osteogenesis imperfecta, in the moderate types, in growing children, these class of drugs have led to fewer fractures, have led to increased ambulation and decreased bowing and deformities of the legs. So that's been very positive. So if you have a patient that is diagnosed with a moderate form of OI, these patients might be candidates and generally are candidates for treatment with bisphosphonates. And that requires them generally to come into the hospital, and they will get this depending on the specific drug given. It can be over a course of a 3-day course, or it could be a shorter course depending on what is being used in your specific area by your endocrinologists who are doing this. The child usually will get this when they're young, about every 3 months, and as they start to get older, the interval can be widened. So instead of every 3 months, it could be every 4 to 6 months, and the dosage might be decreased. So there's a specific protocol that's followed depending on the drug and depending on the child's age, weight, and type of OI. But that generally is given to a child with more moderate OI to severe OI from as soon as we diagnose until they get through puberty.
Excellent. Thank you.
You're welcome.
You also mentioned, fracture care. And since surgery is oftentimes a very big part of a child's life with OI, can you talk about how surgery affects that team approach? And you talked a little bit about having a good physical therapist on that team. What can you, from your experience, tell us about, what happens when a surgery happens and that team approach?
Okay. So when the patient needs surgery, there's generally, we divide this up into, is it elective surgery, meaning something that we have planned, or is it something that occurs, the patient has had a fracture and we now need to intervene with surgery? So in all cases, if you already have your team in place and your physical therapist has been working with the patient that has OI and works with them on a routine basis, so they're seeing them maybe twice a week, giving them a home program to do, and really working on skills, if they have an emergency surgery, then what will happen is the patient will be in good shape and you will do whatever surgery you need. So it can be as simple as just applying a cast, depending on the age of the patient, to basically rodding surgery. And what rodding surgery is you place inside the bone, inside the medullary canal, a rod, and that allows the bone to be held in place and serves as an internal strut. So it helps the bone grow along that rod. The rods that we use nowadays actually will grow with the child, so they expand inside the child's bone as they grow. So that's the most common type of surgery that will be done, and often it is semi-elective because a child has broken through a bone that you were contemplating doing surgery on electively, and you take this opportunity to do the surgery. So having your team in place is important, because then the physical therapist can just say, okay, I know we're going to have a little break because of surgery, so I can't work with your right leg right away because that's the operated leg, but I'm going to continue working with your upper body and continue working on your legs. Years ago, we used to take a patient out of physical therapy. We now don't do that. We continue straight through. And so that's very important. The second thing, at this point, the orthopedic surgeon will also kind of be the driver of when is the patient allowed to weight bear again, and also the driver of when can the patient go back on those bisphosphonates we've been talking about, because it's very important to make sure that the bone is healing correctly before the bisphosphonates will be restarted. If, again, we talk about elective surgery, so now you have a patient with OI, they have bowing of the legs, and they've been on the bisphosphonates, they're doing well, they're now starting to pull to stand, and they're around, say, between 18 months and 2 years of age, you might electively decide that you need to rod the femurs or the tibias, and those are the most common bones that will bow, obviously the largest bones as you're standing. And the indications generally we think about are repeat fracture through the same bone, extreme bowing that's interfering with standing, and those are the big indications for planning elective surgery. And we want the child to be able to pull to stand and start to walk. And we see that, and then we say we can intervene with surgery. So if you're planning that, then the whole team, if you're seeing cardiology, pulmonology, will already know this child is ready for surgery. They will do the pre-op. They will be getting the child ready. So that's why having a team in place is important, not to just ask people at the last minute. And the other key to that is you want the patient also seen by anesthesia preoperatively, not the day of surgery. You want the anesthesiologist to realize that they're going to be dealing with a patient that has more fragile bones, and so positioning patient on the table, doing a safe intubation, controlling for blood loss, having things ready for that are going to be very important. That's, again, we try to be, with the team approach, we're trying to be proactive and anticipate problems as opposed to being reactive, and that's really the key here.
Mm-hmm. Mm-hmm. Excellent. Being at Hospital for Special Surgery, you have that team right there with you, with your patients that you see. What if somebody is, in an area of the country where they don't have a big institution that they can go to? Can you still put together your team without, having the resources at like a bigger institution?
So you definitely, I think that, for physicians, I think we all know people in different fields that are very good at what they do and very interested and very thorough. And I think the key to putting your team together is really to have people who are interested, who are good communicators to each other, and who will then sit together and say, we have this idea of how this patient is. Is this patient extremely fragile, or is this patient a little bit hardier? And many times I know doctors will contact me by email, or they'll call me and just want to run something past me to get an idea, because, again, they're planning ahead. And I think for anyone who's in practice, if you get a patient into your practice who has osteogenesis imperfecta, the key is you've got to take that little extra time at the beginning to get everybody in place that's interested in caring for this patient, and then you'll be fine. I mean, you could be at any hospital, and you are going to have, as the pediatrician, as the surgeon, you are going to have people who have expertise within pediatrics, within your community. And most of those people would be willing, if, approached electively, to participate in someone's care. And sometimes what we find is sometimes the doctors say, can they come in, can my patient come to see you guys? and can you just take a look-see at them and give us a general idea of how you would do it, and then from there, everyone locally can run with that. Because, again, it's important for patients with OI not to have to travel all over. It's important for them to have, their care, if they can, locally, because they're fracturing, they're fragile, and also we don't want to make their OI-ness that all they do is spend time traveling to doctors all over. We want to make it as convenient as possible.
Mm-hmm. Mm-hmm. Yeah, so we probably need a lot more time to talk about this, but I'm going to ask you this question anyway. At the OI Foundation, being a part of the MAC and our priorities here, and you speak to adults with OI across the country for us, that it becomes an issue when you leave that pediatric setting and you are an adult with OI, finding those people that you can put on your team, because now you're sort of the quarterback as an adult. And can you talk about that and the struggles or the opportunities that are there for adults with OI as they're transitioning out of pediatric care?
Right. So that is a huge issue in anyone who has a pediatric or a childhood disorder, and it doesn't go away when you become an adult. And so I think there's a couple of things. One is, I think the parents and the doctors need to make sure that the goal of having your team is that the patient has a roadmap, so that their goals should be, they know where they're heading kind of with their medical care. They know what needs to be done, meaning cardiology every year or pulmonary every year. And their goals should be towards a good quality of life and independence. And that's going to depend, independence is very variable depending on the patient and what their goals for independence are. Some might be just to get around in their wheelchair. Some might be that they want to be able to drive, etc. In putting together the team and the transitioning, my suggestions are those of us who take care of people when they're younger should be able to identify people in the medical field who are willing to take these patients on as they get into adulthood. So if you're an orthopedic surgeon, you should be able to say, you know what, my colleague, Joe will be able to take care of you when you fracture. And I think the doctors can be very helpful in identifying these transition people. Sometimes it doesn't happen, but I think that doctor to doctor is very helpful. And I think also within the OI community, the adults speak among themselves and will say, gee, I found these doctors who are very knowledgeable. But it still requires, because OI is a rare disorder, that the patient has to have their records all correctly, in order, whether they have a binder, have them in order, so that when they go to these new doctors, they can give them this information. And I think the patients also need to know that it's going to take 2 or 3 visits with a new doctor in these fields so that the doctor and they both feel comfortable together. And I think that's the trick, is to think about transitioning as the child gets into adolescence, and the parents, the patient, the doctor all work together to be able to identify these people that would be helpful.
How does that work at your institution, Dr. Raggio? How do you deal with transitioning?
Well, we again are a unique bear here, because for us, I can see patients from birth till they're 100 years old. So I actually see the patients with OI from birth until they're older. And then what I will do is, if someone, say, needed a foot surgery, I will then triage them to the surgeons that I know are interested and able to do that. For medical care, we then get the same thing. We're able to get them to our adult cardiologists right away. So we have a unique setting that we're able to transition people easily, because at special surgery we're not built on whether you're a child or an adult. It's just orthopedics, and then we have all our consultants come in. So it's a little different.
Yeah.
Yeah, it gives us
Yeah, go ahead. That's fine.
I was going to say it gives us a little bit of an advantage, but we also work with patients locally. So people will come to us from far away, and we're able to, say to them, here's what the cardiologist, here's what we would recommend, and here's the tests we would need, and then get that information back, and then we can run it past our experts and say, is this anything we need to be concerned about? And then we can get back to that local doctor. So we try to, we don't want to have patients, again, just flocking in and have to be married to, traveling to New York City. We try to work in a community based with those physicians and those patients. But it does require everybody being very collaborative, and it requires a really good coordinator. And we are very blessed at Special Surgery to have a very good coordinator running the center along with me. So we're very lucky.
So I have a question that's a little off topic here, but I can't not ask it because we have you. And for those of you who don't know Dr. Raggio, she is known worldwide throughout the medical community. She performs basic science and clinical research. So can you talk for a minute about why that makes you so unique, Dr. Raggio? I know there are others like you that are basic scientists. You go from the clinic to the bench to the clinic again. And what makes that such a valuable opportunity for people to see someone like you?
Well, I think, thank you for those very kind words, but I think the key is what I try to do is what's valuable for the patient is I try to look at the patient and say, what are the problems that we're having? What are the concerns? And what are we trying to treat? And then I try to go back to the lab and say, how can I solve that? How can I make their bone better? So let's try different drugs in the animal models. How can I make the patient walk better? Well, let's try these different techniques. And then you go back and try on the patient. So I think if you just go one way, if you're just in basic science and never see the patient, you never really come up maybe with practical solutions for what the patient really needs. And if you never come back, if you just go into the lab and never bring it back to the patient, it's the same thing. You don't know if what you did really worked. So I think it's valuable for the patient to know that you're looking at it, you're taking their problems and then trying to solve it in the lab and then bring it, back to them. I think that's really the basis of this. And then I think the understanding of how bone grows and how if we change one thing that we think is beneficial, we might actually make two things worse. So there's always that, risk-benefit. And basing it in science, I think, helps people. I think it helps people feel like they are participating in their care, and I think it gets people with osteogenesis imperfecta involved in even clinical research then. They say, gee, yes, please put me in a registry, excuse me, because I find this is going to be helpful. By having my information, it might help the generation after me. So I think it builds a very good community spirit also between the doctor, the patient, the researchers, that we're all working in the same goal. And, my goal is basically to make myself obsolete, that, we'll never have to do surgeries again, that we'll figure out a different way of treating OI, and we won't need to do this anymore, which would be great.
Absolutely.
Mm-hmm.
So we have just a couple of minutes left. Do you want to give us some parting words on, to someone that's maybe listening to this podcast that's, that has a new patient with OI, they're a pediatrician and it's their first patient maybe, just a few words of advice as they move forward?
Sure. Definitely what I would say is, you don't have to know the disorder to be able to treat a patient well, and we all know that, we can then go, there's wonderful resources on the OI Foundation site for doctors to look at that are very practical, they're very detailed. There's lots of people to reach out to, so I'm always willing to take phone calls or answer questions. But I think the key thing is to start early with saying to the parents, look, we're in this together, we're a team. You might find some information out there before I do. Please bring it in to me and share. I think being open that way is really helpful because, again, I'm always blown away that parents come in with the latest article that I haven't even gotten to yet, that they're very much aware and they talk on the web. So I think number one is I definitely would set that up early, and then I would sit down and say, okay, you have this type, with the geneticist, and say, okay, they have X form of OI. It is more moderate. We need to get them set up and seen by an endocrinologist. We need to set up who is going to be the orthopedic surgeon who's comfortable with this, and try to do things ahead of time before the patient comes in with lots of fractures. Now, having said that, that's really, pie in the sky somewhat, because generally the patient shows up in the emergency room with a fracture, and then everybody starts running around and saying what's going on, especially if it's a milder form of OI. My other advice is, if you have a patient of yours who shows up in the emergency room and has an unexplained fracture, please make sure that a full workup is done. And what do I mean by that? Have genetics come in and look for everything. Make sure all blood work is done metabolically, looking for thyroid, looking for vitamin D. Someone gets an excellent family history. Because, again, we are the guardians of the children, but we want to make sure that we've done a full medical workup before we say something might be, a non-accidental trauma. And I think that's a really important thing, is that do a complete workup on these patients to make sure that everything is indeed what it should be, that there's no metabolic problem, no endocrine problem. And I think that's important, because you're going to have the two scenarios. The people who come to knowing they're having a child with OI, or just having a child and it's known, and then the patient and the parent who's in the emergency room, and you're trying to sort out what's going on. And those are two different scenarios, but still require the same team. But the team is just working in a more relaxed phase when they come in, knowing diagnosis, versus what's going on phase. And in the what's going on phase, the biggest thing I see is that people forget or overlook doing a full workup of, bone health and, metabolic bone. I think that's the biggest take-home message. And again, if you're thinking of it ahead of time, it makes it a lot easier.
Wonderful advice. Thank you so much. And as Dr. Raggio mentioned, you can go to our website, www.oif.org, and we have information on everything that she talked about today on the website. We encourage you to look at our website. Dr. Raggio, thank you so much. This has been wonderful. We really appreciate your time.
Thank you so much. My pleasure. Thank you, and good luck to everybody out there. Thank you.